start, I think. So my name is Sina, I'm one of the 11 students here, and my project is a patient activation and functional recovery in total hip and total knee arthroplasty. My mentor is Dr. Kevin Bozick. He's a vice chair of UCSF, and he's been guiding me and advising me on the implementation and development of this project here. So we'll start off with an overview. We'll talk briefly about hip and knee arthroplasty, just so we can get some basic facts. We'll talk about the outcomes and the challenges of these surgeries. We'll talk about, in general, hip and knee arthroplasty is a really successful surgery. Patients, over 90% of the patients are very satisfied with their operation, meaning they're happier. They're happier with the joint that they got compared to their native joint. And we'll talk about the challenges and how we characterize challenges and conceptualize challenges with modifiable and non-modifiable risks. And then we'll talk about patient activation and how that relates to some of the modifiable risk factors that patients have a poor outcome. And then that leads to our current study. So total hip and total knee arthroplasty, these are two of the most common inpatient surgical procedures. We don't get a whole lot of exposure to orthopedic surgery during the first 2 or 3 years if you haven't done your research. But hip and knee arthroplasty is kind of on par with percutaneous coronary interventions, PCIs, C-sections, spinal fusion surgery, spinal fusion surgery, so they're very common. But the more important thing is that the demand is expected to grow substantially in the next 15 years. Total hips currently, it's about 200,000. It's going to go up to, by about 200% over 500,000 cases per year. And total knees are expected to go by about 73% now to about 3.5 million cases per year. So the demand is growing exponentially for knees. These are highly efficacious and cost-effective procedures. But there is still room to grow in terms of having better outcomes for the patients that don't do so well. And so just on the right side of the screen, you can see the implant parts that go into the hip. You have the acetabular component, the plastic liner, the femoral head, femoral stem, and the knee implant, you have the femoral component, the polyethylene liner, and the proximal tibia. And these surgeries take about an hour and 15 minutes to do on average. The surgery is pretty remarkable. The patients are able to get up and walk around immediately post-op. What they're limited by is anesthesia. So once the anesthesia wears off, the implant itself is stable, and if they're able to get up and walk around, they can. Patients have surgeries done early in the morning, and have physical therapy done that same day. It's pretty remarkable. And this is just a projection of the total knees and total hips over the next 15 years. You can see total knees and the next dimension, total hips a little bit more of a straighter line. And so, to kind of get a background about total knee arthroplasty, I want to talk about total hips just in the interest of time, but total knee is an indication of the significant and disabling pain secondary to arthritis. So on the bottom left, you can see a patient who's got significant arthritis to the right, it's bone on bone. On the top screen, the x-rays show a right knee, and it shows the AP and lateral view of the implants, and the front and side of the implant. These are elective procedures, and the complication rates are low, about 1%, but those complications are significant. You can have a periprosthetic joint infection, fracture, gum embolism, a loss of motion, and MI and death. Those last two being more risk factors to surgery in general, and risks to being under anesthesia, especially cardiac risk factors. But just to give you an example of how bad some of these complications can be, like infection, for example, a patient has an infection outside of a 6-week window where you could theoretically open up the knee and wash it out, give the patient antibiotics. If they're getting an infection outside of that window, you have two options. You either are chronically suppressed with antibiotics and take antibiotics for the rest of your life, or you undergo a 2-stage revision, and that's 2 surgeries. First surgery, you open up the knee, take out the implants, and you put in an antibiotic spacer into the place where the implants were. The knee has to be an extension, and the patient is placed on IV antibiotics for a range of 6 weeks to months. And then afterwards, the second procedure, you go and take out that antibiotic spacer and put in another prosthesis. And because there's less bone at that point, it's a bigger prosthesis, and it's not quite as functional. And we can have fractures and thromboembolisms that can happen with patients who after the operation are not very active and kind of can lay in bed because they're in pain, and you can develop DVT, that can lead to loss of motion. Dr. goes to say, once the surgery is done, it's erasing its time because the knee is trying to form scar tissue around the surgical site, and so if the scar tissue forms, then that results in loss of motion, and patients may have another operation to break up the scar tissue. So basically, the point is that it's a very active post-operative thing. Patients need to be very engaged in taking care of their health because the surgery itself is half the battle. This leads to a patient comes into the clinic who is eligible for surgery. We talk about the risks and benefits, and this is how we kind of characterize the risks, the modifiable and non-modifiable risks. So in this study of my Santa Rita patient characteristics affecting the prognosis of total knees, younger and male patients have an increased risk for revision, meaning that the more active you are and the more joint stresses you place on the prosthesis, you're more at risk of having a revision. Revision means taking out things and putting into a plan. And typically it's about 15 years, but if you're younger and male, it could be less than that. If you're older and not as active, it can be more than 15 years. And so older female patients have decreased orthoplastic function, and obese patients typically have decreased knee function after replacement. And so these are, with the exception of obesity, are non-modifiable risk factors. Obesity is actually very difficult to modify because, as you can imagine, patients have hip or knee pain. It's difficult for them to be active and try to engage in losing weight. And so that's the Charleston Comorbidity Index. This is what we use to look at 10-year mortality in patients who have comorbidities. And these are, again, modifiable risk factors that we can treat with medications. We optimize patients by managing medical conditions. And we do the best we can. And the more conditions they have, the more at risk they are for having complications. But if patients are willing to take on the risk, typically so we do willing to be partners with them in their care. And so, in going along with these non-modifiable risk factors, there's a growing body of evidence that suggests that the patient's subjective sense of well-being has an effect on their outcomes and interventions. And so this borrows in the fields of psychology and social cognitive theory. Self-efficacy and health show that patients who had a higher degree of self-efficacy had better outcomes in terms of smoking cessation and weight management and collaborative management of chronic illness. They show that patient education and goal setting helps patients manage multiple chronic diseases. And then we learned that we see the trans-theoretical model of health behavior change, highlighted self-efficacy and having a locus of control as being key factors in patients being able to change their behavior. And so this led to a study done by here at UCSF by Dr. Grumbach and Bodenheimer that kind of took this idea of self-efficacy a step further to show that patients were likely to have better outcomes if they're able to kind of do the things that you expect them to do: self-manage symptoms, engage in activities that maintain functioning, involving treatment diagnostic choices, collaborate with providers, and select providers and provide organizations based on performance and quality. And so, moving that field even further, Hibbert et al., this is a group from the University of Oregon, developed this idea of patient activation. And what comprises patient activation is the patient believes the role is important, they have the confidence and knowledge necessary to take action, they actually do take action to maintain health, and they stay the course even under stress. And so this led to the development of the patient activation measure. It's a way to operationalize patient activation. It's a questionnaire. It comprises 3 domains: belief, knowledge, and skills, and the influence of those psychological factors on those 3 domains. And so this is the PAM-22 was the original one. They created a short form. The PAM-13 is owned by Sina Akhavan. I think we paid for it. And so we use this questionnaire to measure patient activation in our patients. And you can see on the left, they're grouped into 4 categories: level 1, 2, 3, and 4. I won't go through all the questions, but you can see the top patient answers yes to this. When all is said and done, I'm the person who's ultimately responsible for taking care of my health. Down to the most activated patient, where I'm confident that I can maintain lifestyle changes, eating right and exercising, even during times of stress.
Sorry, so level 4 is
the most activated. Yeah. And so here's another graph that shows level 1 through 4. Level 1 patients are starting to take a role. Level 2 patients are building knowledge and confidence. Building knowledge but may lack confidence in understanding their health. Level action, level 4, maintaining behavior. And so just to show that patient activation measure relates to health behaviors, you can see that patients, so on this graph, this is from the ORB group, the gold is level 4 and blue is level 1. You can see that patients who are level 4 activated, they're taking hypertension medications recommended, know what their pressures should be, monitor their pressures, and keep a diary. And it also relates to information-seeking behaviors of patients who are activated, read about complications, bring a list of questions to the doctors, are more persistent, and look up the doctor's qualifications. And this relates to assistance too. Patients who are activated are less likely to be readmitted, less likely to experience medical error, have better communication between providers, between healthcare providers, and are less likely to lose confidence in the healthcare system. So they have broad implications. And so this leads to some studies that have been done, and there's several hundred now. There's a couple primary cares, but the majority of the studies have been in primary care. Low activation associated with higher utilization of hospital resources. Figurative that will show that every 10 points in the scale is associated with a 1% reduction in ED visits, smoking, and obesity. And then we've done a more specialized orthopedic care. Skolkowski et al. And JBJS showed that higher patient activations was related to more adherence to physical therapy in spine surgery. In 2011, higher patient activation was related to greater functional recovery in spine surgery. And this is the study that our work is kind of based off of. And then looking ahead, in 2013, the Skolkowski group was looking at an intervention to be able to modify and increase patient activation and see if that had an effect on functional recovery. So this is a graph from the Skolkowski group. You can see, so blue is low activation, gold is high activation. And intensity of current pain is much lower, significantly lower in the highly activated patients. Physical health is rated higher. The OSPES disability index is lower, which is better. And those were all significant. The mental health was, they could not find significant differences in mental health scores, but the rest was. And so this leads to our study of patient activation, functional recovery, and orthodoxy. The hypothesis is that compared to patients with high activation, those with low would have less resolution of the post-op disability, smaller improvements in their physical and mental health following their surgery. Predictor variables are the patient activation measured, demographics, comorbidities, primary diagnosis, and outcome variables are these set of surveys. There are a lot of surveys in each of our patients. The American Knee Society, American Hip Society score, the hip osteoarthritis outcome score, the knee osteoarthritis outcome score, otherwise known as the HOOS, the UCLA activity score, and the SF short form version 12, which is more a generic assessment of patient mental and physical well-being. So our study designed a prospective cohort study of 100 patients undergoing primary knee arthroplasty. The patient activation measures assessed pre-op along with those other surveys I mentioned. And patients are seen at 6 weeks, 6 months, and 12 months after surgery. We currently have all of our 6-week patients have been seen, and we're seeing our 6-month patients now. So for statistics, demographics, initial functional scores are compared across the 4 activation groups, levels 1 through 4. A linear regression model of repeated measures determine the association between our surveys that measure pain, disability, mental health, patient activation, and covariate. And then correlations between activation scores and outcome variables using multiple analyses. So inclusion criteria, things you might expect, chronic OA with the knee, patients who are at least 18 years old, meet eligibility criteria for arthroplasty, and patients who have prior history during replacement surgery are excluded along with those that are out, those who just don't need surveys. So it is a bit of a time commitment. Surveys do take a while, 20 minutes per visit. Patients have 3 visits, that's an hour of their time that they're asking to give. Patients are, we have patients that we get from UCLA, Harvard, and UCSF Orthopedic Institute at Michigan Bay. We have about 100 patients so far at Michigan Bay, and I think 23 or 24 patients over at UCLA. And so this study kind of relates to the patient-centered outcomes research institute. This is an institute funded by the ACA, and the whole idea is to make patients more informed and to really make better healthcare decisions. And it focuses on patient-reported outcome measures as being standards for studies. And so our study kind of goes along with that. And finally, just to talk about my own personal views and why the study excites me, is because I think that in a lot of the surgical fields, a lot lot of the focus is placed on procedure, on implant, on technology, on protocol, and not a whole lot has been focused on the patient itself, outside of optimizing their comorbidities. And I think shifting the focus back to the patient, where you can kind of empower the patient and bring a little bit of, I think, dignity to the patient situation in a situation where patients feel like they have no control, I think is important and places patient and physician on more equal footing during the operation. I think that's really important. And so I think that's it. So many thanks to Dr. Kevin, my PI, Vanessa Chan, she's a research coordinator, and Pong, she's working with the RPI, and all the folks over at the CTR. Thank you.
So, nice job, Sina. We're interested in all of your perspective. This is obviously an important area of research in orthopedics in that we are in the business of improving quality of life. That's really all we do. We don't, we are trying to take people and improve on their function and reduce their pain, and it's extremely hard to do that without an active participant. And so one of the areas of unmet need in orthopedics is identifying who's most appropriate as we get into sort of more limited resources, who's most appropriate for these procedures, who's likely to benefit the most, and how do we optimize that? And we think that patient engagement will be an important way to do that. The first study that Sina's involved with is we want to sort of measure and understand what engagement is and how that relates to functional outcomes, and then ultimately we want to know how do we move patients down that scale from level 1 to level 4 in terms of engagement. Is that something that we can influence prior to considering surgery? But Sina's done an outstanding job in managing the study and has really taken over sort of recruitment as well as follow-up with these patients, and I think we'll all learn a great deal from his work.
Yeah.
Sorry, you didn't mention this, but for the statistical analysis, are you planning to control for things like people who have diabetes or smoking, which might also affect their outcome, their ability to, it might affect whether they get great prostate joint infections, things like that?
Yeah, so those are all in the beginning part, that's initial functions, but those are all compared across this 4 activation years, so you make sure there's no variability in those patients and comorbidities per activation.
But to answer your question, we are measuring the baseline Charleston Comorbidity Index, and then we will make sure that the groups are.
Have there been any studies looking, so at baseline of these 4 different activation groups, what would predispose one person to be in one group versus another, whether it be education, race, socioeconomic status?
I mean, yeah, those are the things. Yeah, education, race, socioeconomic status, previous exposure to the healthcare system. Those are all things that affect patients' activation. And so, these all kind of point to the fact that, especially with the patients being able to have exposure with the healthcare system, that these are modifiable, and that if you are, these are all points of intervention that can help patients have a higher activation.
You mentioned this, but why is there an exponential growth in total knee?
So yeah, and that study looked at the kind of the growth in total knees. That has to do with, in part, aging population. We have more older people, and more than that, more active older people. And so both of those factors together account for
I think I would say it's a combination of prevalence of disease and a comfort level with people, again, as Sina said, wanting to stay active as they get older, and then also a comfort level with feeling more comfortable doing the procedures in younger people. When I started my training, we wouldn't do these procedures in people under the age of 65, and now we see younger people all the time that are severely disabled by this and are, or don't want to wait until they're 65. And so I'd say all of those factors are contributing, but it's creating a real resource problem for us to manage all of these patients, just in terms of workforce issues, being have enough surgeons to service all these patients, and then cost.
Sina, what about the next steps? And how do you describe the differences between these groups? What kinds of interventions are you proposing? what was they were thinking of?
Yeah, so the Stochastic group was looking at, this is what they're doing, looking at having health coaches, patients who can have someone who can help educate them about the procedure, about their history, about their disease, about their particular comorbidities. And so that's the intervention we're looking at. That kind of goes into the realm of shared decision making, and we're doing some work in that as well. And that provides patients with education materials and a kind of like a health coach who helps them develop questions to come in and they come in the clinic that they can ask. And so those are the